Good afternoon, everyone, and welcome to today's PHO Rounds presentation from projections to prevention, what Ontario's illness projections mean for public health. My name is Dr. Brennan Smith. I'm a scientist in population health at Public Health Ontario, and I have the pleasure of co-moderating today's session alongside Dr. Tamara Wallington, Vice President and Chief, Population Health at Public Health Ontario. Dr. Wallington is responsible for leading PHO's work, generating and providing evidence to guide action in the areas of population health. Dr. Wallington will open today's session by providing some context to set the stage for this important work, and will return at the end of the presentation to participate in our Q&A session. Before inviting Dr. Wallington to speak, I would like to start the session by acknowledging the land which PHO is located is on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 of the Mississaugas of the Credit. I will now mention some housekeeping items. So to ensure an engaging and optimal experience for all, the Zoom chat and the audio-video features have been disabled for the session. Please feel free to submit any content-related questions in the Q&A function at the bottom of your window. They will be addressed during the discussion period. And for any technical issues, please email capacitybuilding@oahpp.ca. So I will now pass it to Dr. Wallington, who will provide the introduction for our speaker today.
Thank you so much, Dr. Smith. Well, it is my absolute pleasure to introduce Dr. Laura Rosella today, our keynote speaker. Before we start our presentation, I just want to tell you a little bit about Laura and the context for what we will be discussing today. So to start, Dr. Laura Rosella is a full professor and division head of epidemiology at the Dalalana School of Public Health, University of Toronto, where she holds a Tier 1 Canada Research Chair in Population Health Analytics. Dr. Rosella founded the Population Health Analytics Lab, has authored more than 310 publications, and currently serves as editor-in-chief of the Canadian Journal of Public Health. Dr. Rosella has received numerous honors, including Canada's Top 40 Under 40, election to the Royal Society of Canada, the CIHR IPPH Mid-Career Trailblazer Award, and in 2025 was inducted as a Fellow of the Canadian Academy of Health Sciences. We are very privileged to have Dr. Rosella as our presenter today. To set some context, today's presentation shares the results of a first-of-its-kind report on how Ontario's burden of serious illness is expected to grow over the coming decades. These projections highlight the scale and urgency of the challenges ahead, as well as the opportunities to intervene earlier and more effectively. This work also lays the foundation for a new collaboration between PHO and the Dalalana School of Public Health to expand and adapt the disease model for public health planning. By integrating key prevention indicators and measures of inequity, this phase will support stronger local and provincial decision-making and help shape policies that can meaningfully reduce chronic disease across Ontario. So thank you for joining us today for this very important presentation, and over to you, Dr. Rosella.
Thank you so much, Dr. Wellington, for that very kind introduction, and also Dr. Smith for welcoming me and inviting me to present. And I'm very excited about the potential work we are going to do together. Today, I'm going to, just before I start, mention the disclaimer. This presentation obviously is the work of myself. PHO assumes no liability resulting from this presentation, and I do not have any specific disclosures to report. So let's jump in. I'm going to describe the key findings from a projected pattern of illness report. This is a report that is published, and I'll walk through it initially, set some context as to what we can expect and what it means for us, and then go into a little more detail about the demographic, behavioral, and system drivers that are leading to what we're seeing, talk about what it means specifically for public health, and go into a little more detail on how myself and many others hope that these projections, this report, this methodology, the work that we are going to do in the future really lays the groundwork for health system transformation. And I'll talk more about that. I like to give my main messages up front, so you can have a sense of where we're going. At the end, you can tell me if you got there with what I've been presenting, and I obviously am very much looking forward to your feedback. But again, I'll mention Ontario's burden of illness is rising, and I'm going to walk through an approach and a methodology we've been undertaking the last couple of years to get much more specific on this and really hone in on the role of public health. And you'll hear about how this report came about and how it's really aimed and targeted at the work that public health does. So we're going to talk specifically about the unique role there. And then lastly, I really want to focus on how this turns into action, how this turns into a focal area that brings different sectors across the health system together, how we can build accountability, how this matches to the indicators that we're developing, the evidence that we're generating, as well as applying locally and provincially. So we'll get into how that sort of magic sauce, from my perspective, of using local and population level data combined with modeling, combined with indicators and evidence, is how we enable change in the system. So I'm going to spend the first couple minutes just setting the stage on demographic and mortality trends, because we can't really get into any discussion on future burden of illness without really stepping back and understanding what has actually happened in our society over the past 100 years or so. And this is life expectancy for Canada. Of course, there's life expectancy in Ontario and local levels. But a couple things that you notice when you look at a graph like this, right away, we're sitting at about 82, 83 years on life expectancy in Canada. Of course, it's changing all the time, but roughly around there. And there was a dramatic shift in early 1920s to around 1980s. I'm going to go through some demographic pyramids then, so you can see what's changed. And the thing you don't see when you look at a graph like this is actually there's a ton of variation. In fact, we probably have more variation in the mortality outcomes than I've ever seen since I've started looking at this type of data over my career. There's geographic variation, there's socioeconomic variation, sex and gender differences, all kinds of heterogeneity underlying the trends, and that heterogeneity is growing. And that's just an important message to keep in mind. I'll come back to this a bit later. So let's quickly go through. I'm going to talk a lot about demographic transitions today. And so we got to look at a population pyramid, and I'll show you a few of them. But let's actually internalize what's happened to our demographic makeup. And again, I'm using Canada, very closely reflected in Ontario, and actually many countries have a similar trend. In the early 1920s, we had a pyramid, right? We had lots of people at younger ages, very few people living above the age of 65. Um, by the way, this between the 30s and the 60s is when retirement age was set at 65. It's just kind of interesting to see how different things look now. From a lot of our social and economic structures were set in this time period. We actually didn't have much of a formal health system in this time, but it is the work of public health that led to some of the changes you see. So obviously, public health interventions, sanitation, control of infectious disease, safe childbirth, all of the successes of public health really made this difference that we're starting to see in the other shifts in populations in the 80s to the 2000s, where we see people living longer. We really extended life expectancy. But we see some changes in the distribution of ages across, and this is really important. People living longer than ever before, but we really start seeing the accumulation of major chronic illness, diabetes, cancer, heart disease, etc., and that growth really happening in the 80s and the 2000s. And of course, we celebrate the gains we've made in life expectancy, but are experiencing new challenges with the large onset of chronic illness. And certainly we started noticing this as well. We conducted several studies looking at when people die, what chronic illnesses they were dying with, and noticed that we had a dramatic increase in that most people in the most recent data die with five or more chronic conditions. It used to be about a quarter would die with five or more chronic conditions, and now that's up to well over 65% if we look at this current data. And we also know it's not random in the population. We see distinct chronic conditions accumulating across socioeconomic groups. We also see multimorbidity accumulating differently across socioeconomic groups. And so the idea that we would have multiple chronic conditions is no longer unique, it's the norm. But in fact, a lot of our health system structures are set up, and even some of our chronic disease prevention strategies are set up around singular conditions. So this is a big change that happened over this time period. So last demographic period I'm going to show you is the most recent one. And this was a really interesting article. Stats Canada produces amazing graphics as well as regular articles on the demographic situation. This one was called From Baby Boom to Gray Wave. And showing now that millennials now outnumber baby boomers. We have more people over the age of 65 than under the age of 15, which is the first time in our vital statistics history that we've seen that. So all this to say, this is a totally different world in terms of demographic makeup, the burden of illness in the population, the types of illness we'll see, the complexity of that, and all of our sectors of society, health, social, economic sectors are influenced by this trend and what we're seeing now. We also know, just one last point before I get into the report, that we monitor sort of the number of years in good health. And there's lots of, I know epidemiologists probably on the call. This would be things like health adjusted life expectancy. And in Canada, it's about 10 years difference between lifespan, how long people live, and the number of years people live in good health. So if we're about 82 life expectancy, it's probably about 72. And this is changing over time. This is an important point. I'm going to come back to this as we talk about strategies. But again, I just want to mention this globally. This is a trend not unique to Canada. This is WHO data from about 183 member states where we see that health span, lifespan gap increasing. We also see it distributionally. There's two nodes there because we have different countries at different demographic transitions. But this is a trend that's being seen around the world. And remember that our health systems, our social systems, our economic systems, as I mentioned, were really set up before that gap was growing. And as that gap is growing, it's presenting with a number of challenges. So let's get into the report now that you sort of have the context on the demographics. I think it's really important to anchor on the demographic change that's happening in our country. Probably about 3-4 years ago now, Imtiaz Daniel from Ontario Hospital Association was connecting with the Health Foundation in the UK. They do some really great work if you haven't ever heard of them. A lot of analysis work that with policy relevance, great reports, etc. And they were talking around capacity building. So in the hospital sector, it's really important to sort of have estimates of future burden to plan. And I'm going to talk about how those estimates look and how that came apart. And so Imtiaz reached out to Staney Brown, our dean, and myself at the Dalhousie School of Public Health and said, there's this great new report out of England. It's really having a lot of traction from policy, strategy, and implementation on planning. Is this something we can do? And so that really became the start of a collaboration and the start of the report you're about to see. So we know that healthcare needs are affected by all those demographic trends you saw, all of the epidemiology of most of the chronic conditions leading to those trends, and of course, upstream determinants, the structural and the social determinants of health, and a number of risk factors. And by having those detailed projections in a really robust, transparent way, we can come around and start anticipating and planning. And I know for public health, this is not unusual, right? We're always thinking about prevention, planning, and we think on long time scales. But having the numbers, having the ability to drill down, creating targets and looking at different scenarios really makes a big difference. And that's the focus area that we were trying to close the gap and really try to enable some of those policy and system changes, moving away from a proactive versus a reactive system. And again, I know public health thinks proactively. That's one of the core tenets of public health. But to align as a system on this is really important. And to start asking those questions, how are we going to manage it? And what would it take to change it? And I'll get into that a bit more. Before I show you the results, I do want to mention that this type of exercise that we are undertaking, others have undertaken in different ways, is standard practice in pretty much every sector that's responsible for long-term performance. And public health in general is one of those sectors. But we see that this sort of basic operating principle of thinking 20 and 50 years out, putting numbers and scenarios around that is actually the core practice in most sectors. And I think it's been difficult in health to do this. There's data gaps, there's some methodology questions. And for me, the piece that's been missing, which I'm very excited about now because there's a lot of engagement, is really that link to decision making and turning it into strategy, monitoring, evidence, and action. So there's been a lot of really nice methodological developments on how to do this, but the integration with public health, with the health system sector, with planning, hasn't been as strong historically. And so that's the part that we're really trying to strengthen with this approach. So this is the report. I want to acknowledge Emma Buajidi, who's on the call, our modeling lead, and Imtiaz, of course, and Staney, who did the lead up to this work, and then Professor Monica Alexander, who's a demographer at University of Toronto, a population health demographer. There's a lot of demographic modeling that goes into these types of reports, and all of that expertise was needed. So let me run through what the main findings were. So first of all, on the demographic side, you've already seen kind of the highlight of what the demographic transition's looking like now, but specifically to the year 2040, which was the anchor point we used for that medium to longer term planning. We see that population growth will happen by 36%. The biggest growth will happen among those 65 and older. And the dependency ratio for the first time is going to flip above 50%. So for those of you that don't know what the dependency ratio is, it's the number of the ratio of number of dependents to non-dependents. And dependents from a demographic point of view is those over the age of 65 and under the age of 15. And the ratio to those that are in the working age population. And that ratio is used as an indicator in lots of economic and social policy, because obviously a lot of our economic and social programs depend on a working age population contributing to the social policies and the stability of those to maintain our society. So it's a very important number we're going to cross over by the year 2040. Again, these are demographic trends that are happening. Those are not going to be reversed or if changed very slightly. So let's get into the methodology of the report. And here we did, we sat down with the UK folks to understand what they did and really benefited immensely from, they spent up to 4 years actually creating the report, thinking through how and why they set it up. The first thing that we do, we start with measuring up to 22 conditions that account for the majority of illness in the population. And we do this using linked data, health administrative data held at ICES. And we are able, with those conditions, and in the next slide, I have those specific conditions, account for the majority of health system use in the population. We don't account for every condition. But because this is a burden of illness report with the focus on health system capacity, that's where we're starting. And these models can get very complicated because, to be honest, every single condition we can go down a very deep dive into modeling one condition, never mind a group of conditions. So they landed on this comorbidity score to have a simplified way to be able to describe what the impact will be at the population level and at the system level. And again, because the focus of this report is about actually being useful, being transparent, this methodology was actually quite helpful. So we had to recreate this entire methodology using our own data in our own population. We recreated the weights and we came up with this comorbidity score that basically divides the population into one of three groups: having no illness, some illness, or major illness. And just to give you an idea, so the higher the weight, the more significant the illness. So something like cancer would have a weight of 2.5, whereas something like hypertension would be, 0.08. So depending on the weights and the healthcare utilization, the premature mortality, and the healthcare use associated with that condition, that's how you get into these three particular groups. So that's the score. These are the conditions. Again, 22 conditions. We were actually able to capture more conditions than the model from the UK. And these conditions account for the majority of healthcare utilization in the Ontario context. This gives you just an example of the different morbidity groups. So no illness on average are younger folks. They wouldn't have any major conditions. They probably need some outpatient care at some point. Some illness would be sort of middle age on average and maybe have a few conditions, or probably about one or two, and they would be conditions that can be managed in community care settings for the most part, or there might be a hospitalization here or there. Major illness group really describes people that need hospital care. These are people with major conditions. Most of them have three or more. So most of them would have multimorbidity and require, at some point, repeated or episodes of hospital care. So just to say, from the hospital perspective, they're really focused on the major illness group. These are individuals that will be needing the healthcare system. So last mention of the method, and then I'll go into the results. So we identified those conditions. We separately do the demographic forecasting up to 2040. So the good thing about demographic forecasting, as I mentioned before, it's used in lots of different sectors, including Ontario Ministry of Health, Ministry of Finance, Transportation, all the sectors use these types of forecasting. So they're actually quite robust. And there are low, medium, and high growth scenarios, and we use the medium growth scenarios. So we have age, sex, demographic forecasts, and then the comorbidity weights. And then we have regression-based models that forecast every single specific condition, as well as the morbidity groups, and apply those to the age, sex, demographic projections. And when you put all these together, you get the projected burden of illness. So let me summarize the results. So first, and again, all the results are in the report, so I'm not presenting anything that you can't go look up after, but I want to highlight a few statistics. So first of all, just visually, when you stand back and you look at a graph like this, it's telling you that burden of illness, people living with major and some illness, is increasing significantly in the population. We have about 1.8 million people when we start our observation period in 2002 with major illness, that moves to 3.1 million by 2040 under a medium growth scenario. So to put that in perspective, that's like the entire population of Ottawa and Kingston needing hospital care, in addition to those that need care right now in the hospital by 2040. And obviously, that's significant, knowing that we are struggling to keep pace with the care for the population we have now. And it is somewhat conservative. We're not counting all conditions, we're counting most, and we're using a medium growth scenario. On a per capita basis, the rate is also increasing. I also want to mention the percent living with major illness. So in the beginning of the study period, with our historical data, we're seeing about, around 10%, 10 to 12%. By 2040, 1 in 4 people in the population will have major illness. The average number of conditions they have will increase. So we go from, having an average of 1 to 2 conditions early in the study period up to about 4 conditions by the end. So that's significant because every time you have one condition, adding another adds complexity. And it adds not just medical complexity, but social complexity as well. And the amount of people just with one or more chronic illness, 3.8 million in the study in the beginning, up to 8.2 million by 2040. So Ontarians will be living longer. That's one thing that we noted, but living with more major illness. These demographic pyramids, I think, are a really effective way of showing what was shown on the earlier slide, but just slightly different and really emphasizing. So major illness are these purple bars. So first of all, the demographic transition that's happening, our pyramids sort of turning into columns. And the purple bar is getting bigger and bigger, and it's actually getting bigger in all age groups. So one thing that's subtle when you look at these is actually how the change in purple bars in the working age population as well. And we will start seeing more major illness among the working age population. And this could have implications, of course, if people can't work, require financial assistance, et cetera. So there are lots of social and health implications of this. And I think when we see something like this, it can be very scary. Certainly, it can be very alarming, but also not unexpected. So I know when I saw these numbers, I was alarmed because, again, I'm thinking, how can we manage this type of capacity? Most of these chronic conditions are, disease, cancer, diabetes, osteoarthritis, diseases associated with aging, things that we know from a chronic disease prevention perspective. There are some preventable or delayable strategies, and I'll talk more about that. But seeing the numbers and actually who's affected in which populations is always a bit striking. So let me go on a little bit just to show you a few more exhibits, and then we'll talk about the role of public health in these findings. So we are in the process of we do have costs associated with this, and these are, again, only direct health system costs, so an underestimate. They're not the full health system costs. We do know that those with major illness, healthcare costs are skewed. This is a phenomenon of most health systems, certainly Ontario's health systems. Those with major illness accumulate most of the health system costs, and that's largely due to hospitalization costs. I do want to mention, though, this doesn't mean you just think about only those with multiple chronic conditions and start there. And we've done some modeling work, and I won't go into too much detail, to show that obviously those that are in those highest health system resource use categories have lots of chronic conditions. But if you look back on their trajectory, they start with 0 and 1. And in fact, the vast majority start with 0, 1, and then rapidly accumulate. And with a prevention, with an early detection, with a delay of onset of chronic disease perspective, you can have a very big impact. Once someone has multiple chronic conditions, they need high quality supportive care. and that care needs to be very good and coordinated. So there's lots of work to be done there, but there's also a role for delaying or mitigating the accumulation of chronic conditions. And with our modeling work, we've been trying to emphasize that so that there's complementary activity. Okay, just to show again quickly, this information is in the report and we can come back to this. We can also look at individual conditions. As I mentioned, the fastest moving in terms of numbers, cancer, asthma, diabetes, hypertension, osteoarthritis. Not surprising when you saw those demographic shifts. We also see these shifts on a rate category, and we see that the age changes are significantly contributing to these. The other thing on cost, so this is just preliminary. The next few, well, this slide in particular, we're just starting to incorporate costs. So these are just preliminary results that we're confirming. But basically, what do these projections mean in terms of costs? They really mean about a 5x healthcare cost by 2040, which again makes sense with the 3.2 million major chronic illness that we're expecting in the population. So significant health system costs. And we've also, what we've done, we have linked data on individual level socioeconomic factors as well as some chronic disease risk factors. Just a few are highlighted here. We did include this in the report. We really want to make sure it was very clear that these burden of illness categories that we use to be consistent with the England report are very tightly related to chronic disease prevention indicators and socioeconomic status. So if we look at the income graph here, the red line are the relationship between income and being in one of these categories using a multi-category outcome, and is just very apparent that the chronic disease risk factors are very strongly patterned. Again, not a surprise, but we want to make sure that that perspective is integrated when interpreting these findings. Last, just a couple exhibits just to give you a sense of where this work is going. So with the OHA, we are working on providing some regional analyses. It's very interesting how these patterns actually vary by region and how local regions are using this for planning. So we'll be releasing some of the regional results. The costs and the implications also differ by region. And the conditions and the burden of which conditions where also differ by region. So this is really important to be able to kind of take that macro perspective for planning, but very quickly pivot to information tools that are locally relevant. And that's the work that we're going to be undertaking with Public Health Ontario, certainly for public health regions. So what do all these numbers mean? So first of all, I think that it's safe to say that, I've been talking about these results for a while and I've been looking at them for a while. And I think it's very safe to say that we're approaching a tipping point in chronic disease burden in our populations. And what I mean by tipping point, if we're thinking from a prevention point of view, it's really critical that we ramp up those efforts as quickly as possible. Because if you think about those demographic periods I showed you and the burden projections, those are going to accelerate. So in the we kind of have a decade, I think, to make a significant impact. Not to put pressure on all of us, but the timing is really important. I mean, I know many on the call and many in public health have been dedicated to chronic disease prevention in particular for a long time and would love to see more attention and focus. What I'm saying is I think these numbers really underscore that point and the need for that. The other piece I want to just mention, Ontarians are living longer with major illness. That's very clear from these data. This will not be randomly felt in the population, so we need to think about that. But many chronic diseases can be prevented or postponed. We have evidence-based interventions on individual at the population level. For many things, we know what works. And I want to again emphasize the delay piece. So, because I think when people see the aging, they think that chronic disease is inevitable with aging. And we know from the evidence that even delaying, let's say, diabetes or an osteoarthritis diagnosis from 65 to 70. That has a tremendous impact on these estimates, but also quality of life for the individual and their ability to participate in the daily activities of life. So it's about pushing that as far as possible, and I'll talk more about that. And of course, these results clearly emphasize the need for prevention, and they clearly emphasize that this has to happen in the community. We can't build enough acute care institutions to deal with the burden that we're seeing here, right? That's not the strategy. And I actually don't think anyone's saying that when they see these numbers. But again, it emphasized the distributed nature of health and prevention and how we need to think about it. And as I mentioned, we know the drivers actually through very careful epidemiologic work, through the work of public health. We actually know what's contributing to these. We don't exactly know where, to what extent. That's what the modeling and the data work helps us figure out so we can target our efforts. But we know that a combination of aging, individual risk factors, the social structural factors in our environments is what contributes to everything we're seeing here. Okay, so I'm going to just make one last point to give you something to think about as you think about these results and framing. I've certainly been thinking about this tipping point and actually thinking about these findings as a bit more of an emergency. It's hard because they happen slow. And the impacts of the growth that we're seeing here has a very significant impact on the resilience of our system. So this is destabilizing at a very slow rate. It feels very different from a very acute emergency, but it's happening and it's slower and harder to reverse, which makes it really challenging. But I think thinking about this as a destabilizing factor that's actually affecting the resilience of our systems important. By the way, you throw in a public health emergency like a pandemic or a weather event or flooding or climate change. On top of this, we have a system that's less resilient because of these changes. And so our ability to absorb and respond to those shocks is really challenging. And so when I think about resilience, I think about can we absorb the shock? So can we absorb what's coming? Lots of health system planners are thinking about that. Can we adjust? And that becomes more difficult the more these projections get realized. And then can we emerge stronger? That's really about a different way of doing things. And that for us, practically speaking, is about more care in the community, healthier promoted environments, and making sure that we're delaying the onset of chronic disease as much as possible. And that is a transformation because that's not how our system currently functions. Okay, I'm going to just move us along to talk about what this means for public health. So I've sort of mentioned that I think we've always been in need of prevention. And again, public health has been saying this for a long time. There hasn't always been that level of support or investment, but I think now it's very clear. And we're entering this period where it's really, really important that we double down on those efforts. And as I've just mentioned, this is not just about population health or system burden. It's really about a resilience threat from my point of view, because as soon as our health systems fail, it starts affecting all the other systems in our society that function. So obviously I'm a bit biased, but I think this is problem number one for Canadian society at the moment. So how do we think about this in public health? How do we, and we've always thought about prevention and promotion, health promotion and healthy environments and reducing health inequities, but how can we think about it in a way that synergizes with the rest of the health system that's grappling with what we think is coming? So in many of you will know the term compression of morbidity. And in 1980, James Fries wrote a very popular article on compression of morbidity in the New England Journal of Medicine that talks about pushing the onset of chronic diseases as far as possible into life, towards the end of life. So this figure kind of shows it. We have here at the bottom what we currently experience. As I mentioned, we experience on average, this is of course on average, there's lots of variation, about 10 years of poor health. And The data shows this. What we're projecting with the burden of illness model is an expansion of morbidity. We're having more chronic illness. It's happening at younger ages. So we're having expansion of morbidity. And the goal, if we were thinking of a goal as a target for all of the health system, it's about compressing morbidity, right? So ensuring that people live their longest, healthiest life as much as possible, as long as possible. And you might think, well, that sounds like a nice, nice thought. Who's actually doing this? And I'll tell you that countries are actually doing this. And they're doing this by shifting their priorities in their system, in their strategies, away from lifespan goals, which most countries had. Most countries had goals around life expectancy, reducing mortality, extending survival, including Canada. And they're talking about it in terms of adding 5 years of healthy, independent life, for example. And again, that doesn't mean you just start focusing in older adults. That happens throughout the life course. Extending healthy life expectancy. This is so for the UK's talked about the 5 year of healthy life. Japan has this explicit goal around extending life expectancy. And then there are some talking about the narrowing the goal between lifespan and health span. And it's a whole of government priority because all of the systems in society depend on actually this goal, having people live as long and as healthy as possible, free of disease, able to live in their community as long as possible. And so people are actually rethinking, to me, this is a population health goal. They're not even necessarily seeing it that way. They're thinking as a country goal, as a society goal. So, in terms of us, just a bit more concretely, how can public health turn these projections into prevention? Well, of course, these numbers can help us identify priority risks and conditions. We do that already very well. Public health uses data exceptionally well, mapping, descriptive, surveillance. So, and this just adds to that by adding a future orientation to that, which I think is helpful. But the other pieces are the pieces that I think we're really looking forward to strengthening in our work with Public Health Ontario and other health system sectors, which is about how do we use these numbers to really set some meaningful prevention targets to try and start bending that curve, reducing it, to make sure that we equip regions and local public health units and municipalities and other regional health systems to tailor and plan locally. I think most of the solutions are local, actually. So you need that support and incentive at a higher structure, but it comes from local solutions and that comes with local data. And then thinking about how we can do monitoring and accountability. How can we better position our indicators, our scorecards? How are we going to track progress? Are we going to track our lifespan, health span decline over time? Are we going to track our observed versus what we projected as an indicator of success? And so these kind of three pieces are the parts that I think are coming next in how we strengthen this work. So in just my last few slides here, I want to mention, and this is sort of what I've mentioned already, but I want to emphasize the point that this is also a way to align across the health system. So obviously this is very important to public health, local public health, municipalities. I also think this is a great point around these projections for the acute care and the public health and the primary care system to come together. Everything you saw in those projections involves all of those three different health system sectors to come together. No one sector, not the acute care, not primary care, not public health, can do this alone. And so this also becomes a catalyst for system alignment, which I think is really important and has been challenging just because of the way our systems are built and structured. And I'm not going to tell a public health audience all the levers, but I do talk about these when I present these results in other settings, about the levers that bend these curves really lie in the core work of public health, local public health, as well as provincial public health. And I want to give just a couple very simple examples of how I think this works practically. I think this does come with lots of collaboration with municipalities, thinking about our environments through local organizations and infrastructure and social connections as a key point. on how we bend these curves. So when we talk about health projections, people aren't often thinking about these things I've mentioned here, but they're a missing part of the puzzle. And we're working really hard to try and fill some of the data gaps in these areas and make sure it's relevant locally. This is an example of a project that we're doing with Peel Public Health, where we're working together on specifically diabetes prevention, but I think this can be applied to multiple other chronic conditions and hopefully multiple chronic conditions, where we partner to create the framework of how we're thinking about prevention with community, because it's very important to have that perspective up front. We bring in the modeling and the data, and then we test and identify local solutions that map to that modeling. So this combination of assessing, co-developing, modeling, intervening, and testing is sort of the recipe that we're trying to go towards with these. It's not just about the model and the projections, it's all the pieces around it. And then lastly, I'll mention we have extra data being collected on other aspects which are really lacking in a lot of our administrative databases on the social, the economic, the cultural, the political, and the environmental aspects, which keep people well in the community. So last, I'll just give a preview of what's next. We are working with the pediatric CEOs, the CEOs from the pediatric hospitals across Ontario to try and complement this picture specifically with children and young adults. And we can talk more about that in the Q&A. As Dr. Wallington mentioned, we have a partnership with Public Health Ontario where we're really focusing on trying to do the pieces I mentioned here, which is about local indicators and scenarios so we can enhance strategy. And we do have some partnerships with other provinces. We're strengthening our engagement on this work, so building patient community and partnership tables around this work. And there's lots of complexity on interventions and social determinants of health, modeling complexity that we're working on. So we hope this leads towards success. I always like to end on what success looks like. More years of healthy life, later onset of multimorbidity, narrowing of socioeconomic gradients, slower disease burden. Of course, these are things that public health is focused on, has always been focused on. That's not new. But the idea that we have these models, these shared models to work together on, use these projections in a very strategic way, and then strengthen the work that we're doing in a much more precise way is sort of the goal. So that is the end of my prepared remarks. Hopefully you got my messages that I gave you at the beginning. I want to acknowledge the amazing team, many I've mentioned, including those at the Health Foundation. And thank you very much for your time.
Thank you very much, Dr. Rosella, for such an insightful presentation. I know even having read the report carefully, I learn something new every time I hear you go through the results. And I do agree that some of the results can be a little bit shocking, even having seen them a couple times. So we'll now move into the Q&A segment to answer some questions from our live audience. A quick reminder to everyone, if you have not already, please enter your questions into the Q&A pod. And so there's a couple quick questions, hopefully, around just your approach that I thought maybe you could speak to. So the first one's just about living longer with more illnesses. Can any of the changes over time be explained by changes in detection or diagnosis in your modeling?
Yeah, this is a really great question. Certainly, I'll answer in a couple ways. So it's certainly possible that that's a factor, and we assess this by looking at historical data from almost 20 years back. And when we see dramatic changes in incidence of disease that's above and beyond what we would expect from normal epidemiology, there are ways to adjust for that. I will say in the adult model, it's not really apparent because most of these chronic conditions, we have a bit more awareness of some, and certainly some diagnostic changes have happened, but they've been fairly stable. I think it's a contributing factor, but not a major factor. And there's a practical part of it. If you're getting diagnosed, even if it's a over-diagnosis, you're going to the hospital, and so the health system needs still going to be there, even if we don't think it's a diagnosis that's clinically relevant. you're still going to have all the follow-up and all of that. So from that perspective, but where this is a really good question is in the pediatric conditions. So we are seeing, and those aren't results aren't finalized yet, but we certainly are seeing some dramatic increases that we believe are very much more detection bias and exploring methods to adjust for that.
Okay, great. It's a question maybe you prepare your students for, but will be fun to see your answer. So first of all, great presentation. As we know, mathematical models are only as good as the accuracy of their assumptions, and there are always certain assumptions that we can be less certain of. Example, due to data gaps, which assumptions are you least or most confident in?
Yeah, great question. And I didn't give you a detailed presentation about all the assumptions. There are a lot. It's important to notice and note that there are a lot of assumptions. The big one being that basically there's no major dramatic shift. So I'll tell you one assumption that we've been thinking about that we've been asked about that I'm not sure about, which is the impact on GLP-1 inhibitors. So a lot of people have asked, well, isn't that just going to fix everything? I don't think it will, but any major treatment or prevention let's say breakthrough that could disrupt these are not included here. So that's one assumption that we are making, that there's no major change that's going to all of a sudden put something in the water, magical vaccine, and we can eliminate those. And so I think for the most part, unfortunately, that's true, but there are some uncertainties, one of them being there. The other thing is the demographic projections. So I didn't get into the fact that it also includes immigration. And I feel very unsure about immigration policy going into the future. So we make assumptions based on what we think, but there's obviously been a lot of geopolitical instability in the world, a lot of changes, a lot of talk about that. So that's something I think that could influence quite a bit. It has mixed impacts on chronic disease burden historically. It's made our population a lot healthier and reduced the impact of chronic illness, but it's variable over time. So those are the two I feel uncertain to. But that being said, I the to me the benefit of doing these is about direction, scale, timing, and I feel the model is quite robust to those things. If we start getting down to like, is it going to be 10,000, hips and knees or 10,500? Totally, there's going to be a lot of changes there but in terms of the message of we better get serious about care in the community and prevention, I don't think that changes with any of these assumptions, even the GLP one.
Okay, great. One more question in this kind of vein was wondering whether the model adjusts for the pull forward effect of COVID-19, where many older, high-risk Ontarians died sooner than they otherwise would have, and therefore the population at highest risk would have decreased. I actually
Yes.
read that originally maybe differently. Like I thought maybe that more chronic diseases would be apparent as a result of the COVID pandemic, but I'll let you answer the question.
Yeah, so I think you're absolutely right. So first of all, it doesn't because most of our model is really based on chronic disease and epidemiologic trends prior to COVID for a couple of reasons. One, the data is compromised during COVID because we get this data from healthcare utilization and there was disruptions there. So it doesn't account for that. But what I will say is, I actually think I'm with you, Brendan, that there is going to be a significant increase in long COVID impact, specifically dementia and neurodegenerative diseases that I think we don't fully recognize yet. So I think it's actually a mix. Certainly, unfortunately, we lost a lot of older adults during COVID, tragically. But I also, this is not my area of expertise, but my colleagues in the neurodegenerative space are already talking about earlier and significant onset. So I think it could go multiple ways, but the short answer is unfortunately it's not directly integrated in.
Okay, Dr. Wellington, I wanted to give you the opportunity to ask a question.
And thanks so much. So again, thank you, Laura, for just an outstanding presentation. And I guess I will agree with some of your comments around the projections and the reflection of whether it's 10,000 or 10,500 hip and knee as an example. It's the long-term trend and it's the long-term projection that matters. And I also appreciated the comment in one of your slides around the longer we wait, the harder it is to reverse this trend. So if we start our planning in 2035, it's too late. And in looking at some of the questions that our colleagues are asking, there is certainly a lot of interest in next steps and how do we as a system come together and pivot and align together. And so there are many partners across the system beyond public health. Public health is a core partner. But how do we take this information and start to create the ability to align across sectors, primary care, OHTs. You talked about a really interesting partnership with Peel Public Health and the work that you're doing on diabetes. And so can you share some reflections on what that could potentially look like and how we need to ready ourselves as a sector for this work?
Yeah, I think we need to, I mean, we did this during COVID, right? We had a burning issue and we came together and we figured things out. And we did bring together everyone around the table, including community partners, to make sure we were reaching everyone that needed to be reached. So I think somehow we have to break out of our usual ways of doing things and come together in a bit of a, this is an emergency situation. I mean, longer term, I'll say what leading countries are doing is they think about population health management first. So it's like, how do we create population health management and then and there's a responsible person that does that or organization, and then primary care and acute care plug in. But that I think that's going to take decades to create that kind of model. But places that are building their health system from scratch or really changing them, that's what they're doing. But I think in the interim, if we could have tables where we come together with our goal being adding 5 years of healthy life or whatever we want to call it, compressing morbidity, and make sure we come together. And then obviously we have to be incentivized to do it. I think everyone wants to do it. I certainly hear from everyone in the sector, but if there's no resources, no accountability, and it's actually harder, then it's never going to be done. So I think there's a role there as well.
Totally agree. Brendan, do we have time for maybe one more question?
Yeah, we have so many good questions piling in. But one thing I wanted to touch on, there's a couple around when reports will be available or if the model can be available on
Yeah.
the local public health level to impact decision making. So I want to make sure we touched on that.
Yeah, I think that's a great question. So, and I did forget to mention this. So one of the things we want to do with this model is make sure that it's usable by others. So we don't want to like have a model in a door where we're just running it ourselves. We actually want to make sure that it's available and accessible to the people that need to use it. It's going to take a while to get there and make it, but that's in collaboration with, well, first of all, in collaboration with Public Health Ontario, we're working on PHU specific results that we want to share sooner rather than later. But we will do that with the input of local public health on how and what's the best way to do this. And in the long term, the vision is that this model is available and models are used when people that need to use them can use them themselves. So some easy interface for people to interact with it, generate their own results. That's what we're working towards. And so I hope PHU results next year-ish, looking at Dr. Wallington on exactly what that looks like TBD, but that's what we're working towards. And then some version of people using and interacting with the models themselves in the next couple of years. I think it's really important also for transparency and trust. There are other capacity building models that have been used by health systems and provinces, including our own, but they're behind someone's model. They're proprietary. Like there's all kinds of things. Again, not a criticism. People are using these models, but we want it people to use and being open as possible. I think that increases trust, use, uptake.
Yeah, and I think that speaks nicely to the collaboration with PHO, where we're trying to kind of accelerate that for everyone. So look forward to more consultation to come. If I can sneak in one more question with my own bias here. So there are
Yeah.
some questions around social determinants of health
Yeah.
in here, and so the readiness of governments to go beyond just investing in, say, older populations or really young populations, and considering this the questions around the sandwich generation, and also whether or not governments are ready to really to look at more upstream interventions around the social determinants of health. So that's a lot in a very short amount of time that we have, but I don't know if there's anything you wanted to comment on.
I'll just say quickly on that. I won't answer it directly, but I'll say these types of models help us make those decisions in a much more structured way than just saying what, like we know in public health that thinking about the social and structural determinants is important, but we can show with our modeling and projections why it's important. Because if you just model without integrating those that are more disproportionately affected, you don't have the impact. You aren't able to bend the curve. So what I will say to that is I think that there's nice objective ways to show why that's important, in addition to the reasons we all know in our values of public health with these results. And we've been able to do that with some of the modeling already. And I think that that's something I'm very excited about.
Amazing. Thanks so much. I had to squeeze it in. Sorry to do that
It
to
was a
you at the
great
very
question.
end there. But as we wrap up today's PHO round session, I'd like to thank Dr. Rosella for presenting these interesting findings to us, and Dr. Tamara Wallington for co-moderating the session with me today. I'd also like to thank everyone who joined us for today's event. You can expect to receive a brief and anonymous survey for today's session. Please try to complete this, as it helps us improve our programming. So thank you all, and have a wonderful day.
Thank you both so much. And thanks to PHO.